So we'll continue with pulse volume recording and ABI, ankle brachial index. And these are tests, these are uh, the initial tests that you'll do to make your diagnosis of peripheral artery disease and to follow patients who have peripheral artery disease as well. So if you remember your pulse volume recording, the normal recording looks something like this. The upstroke is very steep, and the downstroke is also very steep. You have a fairly high systolic peak. You have your dicrotic notch, and then you come down to the baseline, then start all over again. So this is what the normal uh, waveform looks like. And then, you know, when you have disease, one of the first thing to go is that you have loss of your dicrotic notch. So this is the dicrotic notch. So you have loss of dicrotic notch. The amplitude is reduced somewhat. If you look at the upstroke is not as steep as over here, and then the downstroke is sort of is not steep, it's flattened. And then with severe disease, you have a reduction in the amplitude, okay, and then everything is sort of flat. Look at the upstroke, look at the downstroke, and so these are varying uh, degree of abnormality. So it's important to note those. All right, so looking at so when you do your complete test, remember it's usually a combination of the pulse volume recording and the pressures. When you do your ankle brachial pressures, you take the pressure in the brachial artery, okay, and then you take the pressure at different levels in the lower extremity, okay. So you'll take the pressure. Sometimes we'll have a two-tie cuff. You can just have a one-tie cuff, but if in this example you have two cuffs on the ties. So you'll take the pressure in the arm and then you take the pressure in the thigh. Remember, the pressure in the thigh supposed to be, or the pressure in the lower extremity supposed to be much greater than the pressure in the upper extremity. Unless there's a blockage in the lower extremity, then the pressure will be lower. So you're going to look at the waveform, pulse volume recording, and then you're going to have the pressures to go along with it. So what you will do is you will do the brachial pressure. You do your low extremity pressure, and then low extremity pressure is all, the thigh, upper thigh, mid thigh, leg, calf, and then you can go down to your dorsalis pedis. So you can even do a uh, toe pressure. And then you're going to put the low extremity systolic pressure over the brachial systolic pressure. Remember, it's ankle brachial index, or the lower extremity systolic pressure over the arm pressure. And that's going to give you a value. That value should be greater than 1. Okay, so in addition to the waveform, so if you look on the right side, so these cuffs on the right side, you'll get your right low extremity pressure, and you get the waveform. So you see that these waveforms look normal. Look at the upstroke, look at the downstroke. You still have your dicrotic notch. So if you look all along there, so you have your ankle, the calf. So for the ankle, so the cuff is right there, the cuff is right there, and then you use your Doppler, or whatever, usually the Doppler, to listen to the dorsalis pedis, sorry, the posterior tibial pressure. You listen, okay. Then the calf, so sorry, this is the calf, okay. Then the lower thigh, this is the lower thigh, and then the upper thigh, okay. So again, you have your aorta coming down, it splits You get uh, the common iliac, then you get your external iliac, femoral, and you go down. All right. So this is the pulse volume recording. Okay. You have the waveform, and you're going to check the pressure. So just to recap the blood vessels in the lower extremity, you have the aorta. The aorta splits to give you the common iliac, and then the common iliac gonna give you your external iliac and your internal iliac. So the common iliac is gonna give you external iliac and your internal iliac. The external iliac comes down and give rise to what we call the common femoral artery. And then the common femoral artery is going to give you a deep branch and a superficial femoral artery branch. Okay, then comes straight down to the popliteal behind the knee. It becomes the popliteal artery, and then that artery divides into three arteries. Okay, on the medial aspect, you have the posterior tibial. On the lateral aspect, you have the peroneal, and then in the front, you have the anterior tibial, and these goes down in the leg and the foot. Okay, so you need to have an idea of the anatomy of the major arteries of the lower extremity. Again, the aorta gives rise to the common iliac, and the common iliac divides into the external and an internal. The external is which continues down to give rise to the common femoral. Then the common femoral is going to split to give you a deep femoral branch and a superficial femoral branch. Okay, we tend to get a lot of occlusion in the superficial femoral artery. You can also get occlusion in the common iliac and the external iliac. So and then of course the blood vessels in the leg. On the medial aspect, you have the posterior tibial. The lateral, you're going to have the peroneal, and in the front, you have your anterior tibial. So when we put a cuff, say at the ankle, you know, you're gonna when you put a cuff at the ankle, you're basically looking at the flow in the I mean, you're looking at the flow all along here, but remember, you're going to have cuff all at varying position. If you have a cuff, say if you have a cuff in the thigh, and the thigh cuff, let's just look at pulse volume recording. If you have a cuff, a blood pressure cuff in the thigh, and if it show an abnormal recording, then it suggests that you have a blockage above where the cuff is placed. Okay? Again, if the cuff is in the thigh and you have an abnormal waveform, it suggests that there is obstruction above the cuff. So it would be either in the, it would either be in the aorta, okay, or it can be in the common iliac or the external iliac or the common femoral, okay, if the cuff is right there. If you have a cuff, say, in the upper thigh and one in the lower thigh, and if the upper thigh waveform is normal and the lower thigh waveform is abnormal, then it suggests that there's an obstruction in the superficial femoral artery. Okay, if you have a cuff in the calf or the leg, and the cuff in the lower thigh is normal, the waveform in the lower thigh is normal, and this is abnormal, then it suggests that the obstruction is between here. Okay? And similarly, at the ankle, if everything above the ankle is normal and this is abnormal, then it suggests that the obstruction is right there. And we're going to go over that. So, depending where the cuff is placed, and the abnormality you get in the waveform, you can determine where the obstruction is, where the blockage is. And so you're not only going to look at your pulse volume recording, the waveform, but you're going to do your ABI, ankle brachial index, or the pressure in the lower extremity to the pressure in the upper extremity. So again, just to recap what peripheral artery disease is, it is blockage of the blood vessel that, the artery that runs in the lower extremity. So the blood vessel supposed the lumen or the wall of the blood vessel supposed to be nice and smooth and blood flows unobstructed. But when you have a blockage or peripheral artery disease, it is similar to what occurs in the blood vessel around the heart. The the bad cholesterol, which we call the LDL, low density lipoprotein, becomes oxidized, and that is taken up into the blood vessel wall. So the oxidized LDL is taken up into the blood vessel wall by cells we call macrophages. And then these eventually grows and form these plaques which obstruct the blood flow in the arterial system. Okay? So now you have obstruction. And because the tissues below the obstruction cannot get uh, blood supply. Remember, the tissues need oxygen in order to manufacture energy. And so if the tissues are not getting energy, they they're gonna it's gonna manifest as a varying disease state. When you have peripheral artery disease, you can have certain changes in the lower extremity. You can have you're going to have loss of function. That is, if the patient have had air on in that area, you got loss of hair, you breakdown of tissue, you can have pain, okay, reduction in the pulse, you get pallor, okay, stuff like that. We went over that before, but this is what the obstruction looks like. And if you can diagnose it and locate where the obstruction is, then you can do something about it. All right, so again, you're going to have your cuffs. Sometimes you'll will just use one in the thigh, one in the upper the leg, and then the ankle. Sometimes we just have three, but you might have four. So you have an upper thigh, a lower thigh, the calf, and the ankle. Okay. So again, if the upper thigh is abnormal, then it suggests that there's an obstruction, probably from the aorta, common iliac, or external iliac.
Right, right.
Okay, so anything above here, if it's abnormal. If this is normal and this one is abnormal, then remember the superficial femoral suggests that there's a superficial femoral block. If this is uh, normal and then these are abnormal, you have the popliteal, which is right there. So if everything up here is normal and then the calf is abnormal, then these vessels these vessels in the leg. So remember you have on the medial aspect you have the posterior tibial, on the lateral aspect you have the peroneal, and then the anterior tibial. So these waveforms are normal. This is normal waveform, as opposed to on the left side you can see, if you look at the peak, the
Inversion.
systolic peak is reduced. The upstroke looks okay, but you can see that the downstroke is not as very steep. And then similarly for the lower thigh, and these are abnormal. So this would suggest that there obstruction above this cuff. So the obstruction is somewhere here. The reason why, if you look at this carefully, the obstruction is not going to be in the aorta because the right side is completely normal. If both sides were normal, then the obstruction would be in the lower, well, in the aorta. But because the right side is completely normal, the obstruction is somewhere along here. Okay, so it could be the common iliac or the external iliac. So just looking at the waveform, but you have to do the pressures as well. All right, so this just look at the localization of the disease. So again, it's the break, same thing for the pulse volume recording as the ABI. We call it the ankle brachial index. It's just a low extremity systolic pressure over the upper extremity pressure or the brachial pressure. So if there's an abnormality in the upper thigh, so as we said again, if the abnormality is right there, then it could be the aorta iliac. It could be from the anywhere in the aorta, the common iliac or the external, um, or the common femoral. Okay, if it's the upper thigh, we wouldn't really. You're not going to get much of the superficial femoral artery, so I wouldn't really put this right there. So if it's the upper thigh, it's mainly the aorta iliac right inside here, or the common iliac. Okay, and probably the common femoral artery as well. If the upper thigh is normal, and then the upper calf is so the upper calf is abnormal. So the abnormality is between the upper thigh and the upper calf. So the blood vessels that you're looking at is the superficial femoral artery and the popliteal. Okay, and then for the if the abnormality is right inside here. So this is normal, this is abnormal. So the abnormality is going to be in the tibial blood vessels. So remember, you have three blood vessels there. Okay, and then if you're going to do the toe brachial, then it, usually abnormalities in the small vessels down here. So this just give you a rough guide. Where you have the abnormality, you can localize the blood vessel involved. Okay, just to go over the waveforms again. Remember the normal waveform. You have a nice upstroke. You have the peak systolic. Then you have your downstroke, your dicrotic notch. When it's mildly abnormal, you lose your dicrotic notch, and then your downslope is a little um, is not as steep. Moderately abnormal, the peak is reduced, the downstroke is like that, and then severely abnormality, the peak and everything is abnormal. So just looking at the anatomy of the curve, we talk about the upstroke. You want to see a nice rapid upstroke, your sharp systolic peak. Then this is the dicrotic notch which we've been talking about. And then the downslope, it bows towards the baseline. So there's a bowing. So this is what the normal tracing looks like. Your rapid upstroke, sharp peak, the dicrotic notch, and then your downward slope. It bows towards the baseline. So when it's abnormal, then when you look at the upstroke is not as steep. Okay, the flatter rounded peak, so it's not a sharp peak, flat rounded peak, and then the dicrotic notch is absent, and then the downslope bows away. It bows away from the baseline. See this there's an indentation there. So the baseline, it bows away from the baseline. Okay, so this is what the abnormal tracing looks like. So you want when you do so again, you're going to have your cuff at varying position on the lower extremity. Okay, you can have three, four, sometimes you can have five cuffs. Okay, and you want to see your nice upslope, sharp peak, steep downslope. You want to see your dicrotic notch, and it should be the same on both sides. Okay, so you're going to do your waveform pulse volume recording, and you're going to do segmental pressures. Again, the pressures in the lower extremity, systolic pressure that is, should be greater than the systolic pressure in the brachial. The minimum should be a 1-to-1 ratio, but it should be a little bit higher. Okay. So again, if you look at, this have one, two, three, four, five. So they have a ankle, a calf, they have a upper leg, they have a lower thigh and an upper thigh. Okay. So again, you want to see your nice upstroke. You want to see a sharp peak. You want to see a steep downslope dicrotic notch. Okay. And then if you look on the left side, the peak is sort of rounded. Okay. Peak is rounded. There's loss of the dicrotic notch, and then the reduction in the peak, and then reduction in the amplitude again. Then the upstroke, if you look at the upstroke, it's not very steep. Downstroke is not very steep as well. Your loss of the dicrotic notch, and then reduction in the amplitude. So if you look at this, the abnormality starts occur in the upper thigh. So again, the right side is completely normal. So if the obstruction starts in the above the upper thigh vessels, then it's probably in the common iliac or the external iliac or the common femoral. Okay, so all the blood vessels above here, but not including the aorta, because the right side, if it includes the aorta, then it would be, the abnormality would be bilateral, right and left. Since it's only on the left side, then it's going to be only in the left-sided vessels, okay? Not the aorta, because the aorta is common to both the right and left. And these are just looking at some of the pressures. So if the systolic pressure in the arm is 150, you expect it to be the same or greater in the lower extremity. But you see here, the upper thigh is 150. Then you start having a falling off of the pressures. So you can do the ABI at different levels. You can do the ABI right here to be a 1-to-1. Systolic would be 1-to-1, to be a little bit less, little bit less, little bit less. And then when you get to the ankle, it's very low, 0.44. It's very abnormal. So, just like how you look at your pulse volume recording for varying levels, you can do the ABI for varying levels, or you can just do the generalized ABI from the ankle to the brachial. So just to recap, the range of ABI. If the ankle brachial index, that is the systolic pressure in the lower extremity to the systolic pressure in the arm, if it's more than 1.3, we talk about a false elevation. And usually the blood vessel is heavily calcified. So, it's not that it's super normal, it's just that the blood vessel is calcified. So it gets a false elevation. The normal range of the ABI is 1 to about 1.29. So this is a normal range. If it's between 0.9, 1 and 1.0, we say it's borderline. So once it's below 1 to 0.9, we say it's borderline. For mild PAD, it is 0.7 to 0.9. And then moderate is 0.4 to 0.69. And then severe PAD, which is associated with critical limb ischemia, ulceration, and rest pain, is 0.4. So these patients are in misery because they have rest pain, they have ulceration. These patients need immediate attention. Also, your moderate PAD, these patients need urgent attention as well. So this is the range of your ABI and the type of disease that's associated with it. All right, so we do all of this. How do we manage these patients? What should we do when these patients come with varying abnormality? So the the American College of Cardiology and the American Heart Association guideline for the management of PAD using the pulse volume recording ABI. So these are individual at PAD risk if they have no leg symptoms or atypical leg symptoms. Remember, if the patient have critical limb ischemia or they need immediate attention. So these are individual at uh, peripheral artery disease risk, no leg symptoms or atypical leg symptoms. Consider using the San Diego walking impairment questionnaire. Okay, you're going to perform a resting ankle brachial index measurement. So again, these are not patient in extremis. If someone come and they have rest leg pain and ulceration, this is not necessary. These are for patients who are relatively asymptomatic. So you're going to do your ABI, and if your ABI is greater than or equal to 1.3, then we talk about non-compressibility. It could be due to heavy calcification of the blood vessel. So you want to do your pulse volume recording, your toe. So you'll do your toe brachial index, or you can go on to duplex ultrasonography. So if the ABI is greater than or equal to 1.3, you want to do your toe brachial index. So you want to put the cuff on the toe and pulse volume recording. If you get normal results, then the patient have no PAD and you don't need to do anything more. If you get an abnormal results, then you confirm the diagnosis and then you do your the additional workup. Okay. If you do your ankle brachial index and it's 0.9 to 1.3, which we said is borderline or normal, if the patient have symptoms, if that patient tell you that whenever I walk, I have pain in my calves or pain in my thighs or something like that, then it suggests claudication. So what you want to do with this patient, this borderline patient, you want to put them on a treadmill. So you're gonna measure the ABI after exercise, just like you do a stress test for uh, patients who present with chest pain. So if it's borderline and the patient still give you uh, a history that they have pain in the leg when they walk, you do a stress test. So if the stress if its stress test is normal, that is no post exercise ABI. So what you're going to do, you're going to exercise the patient, then you do the ABI. If they have significant obstruction, then the ABI is going to be less than 1, much less than 1. Okay, so no post exercise ABI, then it's no PAD. All right, again, for these borderline patients with resting ABI between 0.9 and 1.3, you exercise them on the treadmill and you do the ABI uh, after the exercise. Okay, if it's abnormal, if you have decreased post exercise ABI, then they do have PAD. You confirm the diagnosis of PAD. And then the next category is when you do your resting ABI, if it's less than 0.9, then it's abnormal. You confirm that they have peripheral artery disease, and then you can manage them appropriately. Okay, so those are the rough guidelines for patients with PAD. So we have looked at our peripheral artery disease using PVR and ABI to assess these patients. We know what the normal waveform looks like. We know what the abnormal waveform looks like. And then we have a general general guidelines to take care of these patients. What we're going to do next is you look at ultrasound, duplex ultrasound to evaluate these patients.